that I gave in microbiology, the antimicrobial section. So those questions, they're my responsibility. So I think that you should probably focus your studies on the stuff that we talked about in class. But I think you're also doing yourself a disservice if you don't do the reading. That's true, not just for this, but for everything. You should read the book. I don't understand that. In some ways, I don't understand the model student. I understand you got a lot to do. You all have a lot to do. When you shortchange yourself, But I did write the questions, so that will work. All right, let's talk about hypernatremia and hyponatremia. And hypernatremia, again, refers to an increase in the serum sodium concentration above normal, whatever normal is, so let's say 440. And hyponatremia is going to refer to a decrease in the serum sodium concentration below normal. Let's talk first about hypernatremia. And hypernatremia, the book divides their discussion of hypernatremia into a couple of different kinds. Okay, so you can think about this in terms of the stuff that we talked about with the figure 3.7. So the first type of hypernatremia that they refer to is hypervolemic hypernatremia. So these are patients who are volume overloaded and have hypernatremia. And they give you a couple of examples of that. Some of them should not be surprising. So they say, for example, intimidate astrogenics in the administration of a sodium-containing solution. So give a hypertonic solution, as we saw in panel 1, you can end up with hypervolemic hypernatremia. Another example, another thing that can cause that clinical condition is primary hyperaldosteronism. Aldosterone, you remember, is made by the zona glomerulosa of the adrenal gland. The mineralocorticoid is responsible for sodium reabsorption in exchange for potassium and proton. Okay? So if somebody is overproducing aldosterone, if they have a tumor that's overproducing aldosterone, too much aldosterone, they're going to tend to reabsorb serum sodium. Okay? Well, where sodium goes, water follows. Okay? So they're going to tend to be volume overloaded. Okay, they'll develop hypertension. Okay, they generally have hypokalemia because think about what aldosterone does. It reabsorbs sodium in exchange for the sodium-potassium pump in exchange for potassium. So sodium is being reabsorbed, more potassium is being secreted into the urine. So they have hypertension, they have hypokalemia, they have a metabolic alkalosis. Because again, what's happening is sodium is coming in exchange for other positive ions, right? And the other positive ions are potassium and proton, H+. So if H+ is going out, what's left behind is, if acid's going out, what's left behind has to be alkaline. Okay? So patients that have primary hyperaldosteronism, they have hypertension, they have hypokalemia, they have metabolic alkalosis. They have the serum sodium elevation is usually mild in the 143 to 147 range. And what would you expect would happen to their serum or their plasma renin? Decrease. Huh? Decrease. Somebody say it loud.
Decrease.
Right? Huh?
Decrease.
Yes. Why is that?
Because the effective volume that the kidneys feel or see will be higher, so
right.
They're going to decrease the.
That's right. So plasma renin activity is going to be down. All right, and that's how you know it's primary hyperaldosteronism. If it's secondary, then the plasma renin activity would be up. Right? So renin, angiotensin, aldosterone. That means that the aldosteronism is secondary to the hyporeninemia. Okay. The second category of hypernatremia is hypovolemic hypernatremia. And if somebody's hypovolemic, then as you know, they have to have sustained a fluid loss. And if they're hypernatremic in the face of that hypovolemia, then that means that they're losing more water than sodium. They're And the book points out that patients can suffer this loss of free water in two ways. They can lose it either renally or extrarenally. So the free water can be lost in the kidneys or it can be lost in some other way. Patients, renal losses can happen, for example, if they have obstructive neuropathy, and then they can develop a post-obstructive diuresis, okay? Or you can have a renal loss of fluid if you put somebody on a diuretic, and they are losing mostly free water. They're losing more free water than they are sodium, okay? Extrarenal losses of relatively free water can happen if there's losses in sweat, for example. And you can distinguish between renal and extrarenal losses of fluid by checking the serum sodium. Okay, so if you check the not the serum sodium, check the urine sodium, spot sodium. So you ask for spot sodium, urine concentration. Take a sample of urine, send it to the lab, and ask them to do a sodium concentration. If the urine sodium concentration is greater than 20 milliequivalents per liter, then that suggests that the sodium losses are renal. And if the urine sodium concentration is less than 20, that suggests that the losses are extrarenal. Yeah.
Is there a particular type of diuretic that does these renal losses better than others, like a loop diuretic?
Loop diuretic will probably all diuretics, but loop diuretic will do it. Yeah. The third possibility is the only one that's left, which is euvolemic hypernatremia. So these are people who are euvolemic, they have a normal volume status. Associated with hypernatremia. And they give you a couple of examples of that. Loss of the first mechanism, hypodyspsia, resulting in decreased water intake, or diabetes insipidus, which is the loss of the ADH. Now remember, taken to an extreme, patients with ADH can develop problems with their bodies, but they're talking about a milder form early on where the person has access to water. There's a couple of different types of diabetes insipidus. There's central diabetes insipidus. You know that you have the pituitary, the anterior, the posterior pituitary, and the posterior pituitary is responsible for releasing hormones of ADH and oxytocin. So in central diabetes insipidus, you don't have production or release of antidiuretic hormones in the central nervous system, central diabetes insipidus. With nephrogenic diabetes insipidus, that's the other kind of diabetes insipidus, you have production of ADH, but it's not working on its receptors, and the kidneys are not responding to the antidiuretic hormone which is being produced. That's referred to as nephrogenic diabetes insipidus. And the book points out that you can have nephrogenic diabetes insipidus for a couple of reasons, either because you have a mutation in the DNA that codes for the receptor protein. So you have defective receptors for ADH. That would be one cause. Or certain drugs can cause nephrogenic diabetes insipidus. And the example that they give you is lithium. So lithium can be associated with nephrogenic diabetes insipidus. Again, if you want to distinguish between central and nephrogenic diabetes insipidus, you can check the antidiuretic hormone levels. It's going to be high in nephrogenic diabetes insipidus, and it's going to be low in central diabetes insipidus. The other thing you can do is you can gauge the response of the patient to exogenously administered antidiuretic hormone. That's depicted in figure 3.9, page 57. You have a person that's producing excessive amounts of dilute urine. You administer antidiuretic hormone analog. And in somebody that has central diabetes insipidus, that should correct the problem. So you see an increase in the urinary concentration and a decrease in the urine volume. Whereas somebody that has nephrogenic diabetes insipidus, since the problem is that the level of receptors, it's not going to make a difference. And these people are usually, the diagnosis of diabetes insipidus is usually made with a water deprivation test. So if you suspect diabetes insipidus, usually somebody hospitalized, they're put into a controlled environment, you deprive them of water, and you follow the plasma sodium concentration, the plasma osmolality, and urine osmolality very closely. And there are guidelines for stopping the test. Like when the serum sodium concentration or the urine changes a certain, that you make the diagnosis or if the person runs into any problems in terms of hemodynamic status, you can look it up today to tell you how to do the water deprivation test. But it's one of the ways that diabetes. Okay. And if you look at figure 310 on page 58, they give you a list of the different causes of some of the different causes of hypernatremia. You should feel comfortable, okay, with each of those conditions. And if you're asked, like, if the person has a certain diagnosis, you should feel comfortable saying, okay, this person has hypernatremia with a normal body status. This person has hypernatremia with hypovolemia or hypernatremia with hypervolemia. Okay? By the same token, if you're given, let's say, a condition such as hypovolemic hypernatremia, and you're given 4 conditions, and you're told to pick out the one that makes sense, you should be able to pick that one out. Okay? So I want you to be able to work in both directions. And in order to do that, you don't want to just memorize it. You don't want to memorize this stuff, right? You want to understand what's going on. You understand the physiology of what's going on. So make sure you understand it. Does anybody not understand what we're talking about so far today? Everybody not yet? Well, the other side of the coin is hyponatremia. Hyponatremia refers to a decrease in the serum sodium concentration. And you probably see this more than you see hypernatremia. This is something that you'll see more in clinical practice, hyponatremia. And of course, when they start to get really hyponatremic down in the 120s, especially down in the low 120s, then you really start to worry about them developing neurological problems, including seizures. And whether somebody's going to develop a problem from hyponatremia depends on a lot of things, including the severity of the hyponatremia. So 116 is worse than 122. Okay? But it also depends on how quickly they develop. So if they develop it over a long period of time, then they're able somehow to habituate, maybe by use of other osmoles and things like that. So the rapidity with which the condition develops says a lot about how they're going to tolerate it clinically. And remember, we talked about the importance of whatever the serum sodium level is, you don't want to correct it too quickly. Right? All right, so let's talk about the 3 different types of hyponatremia. The first one is hypervolemic hyponatremia. And we've alluded to these conditions before. These are people who have an increase in total body water, but a decreased effective circulating volume. So if you measures the volume on the arterial side of the circulation, in other words, what the kidneys are saying, it would be decreased. And so you can see this, for example, in patients that have congestive heart failure, in patients that have cirrhosis with ascites, and I think probably nephrotic syndrome is an example of that. But let's just limit ourselves to heart failure and cirrhosis. Yeah, nephrotic syndrome is another example. I think it's 313 on page 60. So what's happening in these people is that because of the decreased effective circulating volume, the kidneys are seeing less blood, they're seeing less cardiac output, so they ramp up the production of renin. Renin causes renin, angiotensin, aldosterone, so these people develop a secondary hyperaldosteronism. But the aldosteronism is secondary to the hyperreninemia. It's different than primary aldosteronism that you get patients that have, let's say, an aldosterone secreted in the adrenals. Okay? The second category is hypovolemic hyponatremia. And as we saw in the situation with hypernatremia, so again, these people are losing fluid, but in this case, they're losing fluid that is relatively rich in sodium compared to what we saw in the situation with hypernatremia. So they're losing fluid that's relatively rich in sodium. Again, the losses can be either renal or extrarenal. And as we saw in the situation with the hypernatremia, you can look at the urine sodium concentration. If the urine sodium concentration is greater than 20, then the source of the loss is renal. If the urine sodium concentration is less than 20, then the sodium is being lost extrarenally. And then finally, the last category of hyponatremia, and this is also a common, you'll see this a lot in practice, is euvolemic hyponatremia. The paradigmatic example of euvolemic hyponatremia is SIADH, syndrome of inappropriate antidiuretic hormone production. And the name tells you the pathophysiology. Okay? What's happening is that these people are producing SIH, they're producing antidiuretic hormone. Now remember, normally the body produces antidiuretic hormone in order to maintain what? Huh? No. No. Remember, water is responsible for volume, but water metabolism is not. So the body releases antidiuretic hormone normally in order to maintain osmolality. Okay? So what's happening in these people is that they are inappropriately producing ADH at a time when they should not. What that means is that they're going to reabsorb free water. The kidneys are going to reabsorb free water more than they should. So the serum sodium in the bloodstream is going to go down. Can you see that? That's SIADH, syndrome of inappropriate antidiuretic hormone. You can see this in a number of different conditions, but one of the conditions you can see it at is what we've already talked about. What do you think? One condition where you can see SIADH. We've talked about it. No. It's an actual clinical condition where you can see SIADH. Huh? What? What is it? Well, yeah, you can see it. You can see it. Okay, that's fine. You can see for lots of reasons. You can have people that have pulmonary disease. You can have people that have central nervous system disease. But the condition that we've talked about, yeah. What? Diabetes insipidus? No, diabetes insipidus. Oh, they have. Right. So the condition is Remember when we talked about the paraneoplastic syndrome? Paraneoplastic syndrome, one of the paraneoplastic syndromes is SAEH. Syndrome is inappropriate antidiuretic hormone. Okay? You can have tumors that release, of course, release of antidiuretic hormone. So, okay. So the diagnosis of SIADH, you see that in the discussion of euvolemic hyponatremia, they give you a differential diagnosis here, the conditions that can cause it. They say adrenal insufficiency, hypothyroidism, primary polydipsia, SIADH. So the thing, if you remember SIADH, you will remember everything else about this condition, because in order to make the diagnosis of SIADH, you must exclude adrenal insufficiency, renal insufficiency, and hypothyroidism and thyroid disease. You have to exclude those things, otherwise you can't make the diagnosis. Okay? You're going to go ahead. Renal disease, adrenal disease, and thyroid disease. And that tells you that those other conditions are on the differential diagnosis of euvolemic hyponatremia. Again, you're going to suspect SIADH in a patient that is euvolemic, so they're clinically euvolemic. They don't appear to be volume overloaded. They don't have any edema, okay? And they don't appear to be volume contracted, so they don't have, drive up of mucosal, loss of axillary sweat, tachycardia, orbital stasis. They don't have any signs or symptoms of clinical volume overload or clinical dehydration. All right? Yes, at the bottom of page 58, they give you the differential diagnosis: intracranial pathology, paraneoplastic syndrome, which is what we just talked about, pulmonary disease. Certain drugs can cause the syndrome of inappropriate antidiuretic hormone. I think the mechanism of those drugs induced effects was not clear the last time I checked. So if you check a urine osmolality, what would you expect to find? Would the urine osmolality be higher than normal or lower than normal? Be higher than normal, okay? Because serum sodium is going to be low. The way the kidney should respond to a low serum sodium is by excreting free water. So you expect the urine osmolality to be low. The kidney should be secreting a dilute urine. But the urine is more concentrated than expected. And I think, the last time I checked, urine osmolality is greater than 100 milliosmoles per liter. And that would be consistent with the diagnosis. Urine sodium greater than 20. Urine osmolality greater than 100. And if you remember back when we talked about renal failure, when we talked about fractional excretion of sodium, the fractional excretion of sodium is going to be greater than 1% in patients that have SIADH. Again, the differential diagnosis of each of those categories of hyponatremia are shown in figure 313 on page 60. And I want to spend just a little bit of time talking about the fourth category, which is pseudohyponatremia, which is important to talk about. So let's talk about, discuss at page 15 at the bottom. Pseudohyponatremia at bottom page 59. So they have there the formula for serum osmolality, for calculating serum osmolality, and you see that most of the serum osmolality is going to be provided by serum sodium, but you see that glucose and urea also play a role. For our purposes, let's focus on the glucose. If somebody has a really high blood glucose, which you can see in somebody with hyperosmolar coma, diabetic hyperosmolar coma, or somebody that has diabetic ketoacidosis, then that number in the numerator can be quite large. Okay? So, depending on that number, okay, the serum osmolality can go up. They can develop hyperosmolality. What's going to happen is that the serum sodium is going to tend to move in the opposite direction in order to try and maintain normal osmolality. So the serum sodium concentration is going to change by 1.6 milliequivalents per liter for every 100 increase in the glucose above normal. So if the normal serum glucose is, let's say, 100, okay? Right? And let's say a normal sodium is, let's say, 140. Okay? Let's say somebody comes in with a blood sugar of 1100. Glucose is 1100. What would you expect the serum sodium to be if you measured the serum sodium in this patient? Huh? It changes 1.6 for every, what would you think it would be? Huh?
Sodium would be 156.
Well, no. The sodium should go in the opposite direction, right? The sodium should go down. If the glucose is high, remember the glucose is osmotically active, okay? So it's going to, the sodium is going to tend to go in the opposite direction to try and compensate for that hyperosmolality, to try and maintain normal osmolality. Okay? So what's going to happen is that it's going to go down 1.6 for every increase in this above 100. So that's 1,000. 10 above that. 100, 10 times 100 is 1,000. So 1 over 1,000. So 10 times 1.6, which we got that in 16. So it's going to be 124. Now, if you measure the serum sodium in this patient, what we say is that, oh, he's hyponatremic. Bless you. Yes, but it's pseudo-hyponatremia. It's referred to as pseudo-hyponatremia because it's compensatory. So if their serum sodium in this person, they wouldn't really have hyponatremia. They have a low measured serum sodium, but this is compensatory, so we would call it pseudo-hyponatremia. Okay? So likewise, if they had a serum sodium of 140, well, they'd be hypernatremic, relatively hypernatremic. And if they had a serum sodium of 104, then they'd have hyponatremia. They'd have pseudo-hyponatremia with real hyponatremia superimposed on top of it. Can you see that? So this is the expected number. And the formula is 1.6 times for each rise in the serum glucose above 100. Okay? And you can change the number. Make this 600. Okay? And then it's 5 is 100, 500 of that, and 5 times 1.6, so it would be 8, so then you'd expect 130. Okay? You should be able to do that calculation. The other conditions that they list under pseudo-hyponatremia, so that's the hyperglycemia. Forget about the hyperuremia. The hyperlipidemia and the hyperproteinemia are associated with a decreased plasma water fraction. So these people have a low measured serum sodium concentration with a normal osmolality. So what does that mean? So let's take it. Do you want to explain it? Okay. What's that? They multiply 1.6 times the number of hundreds that the measured serum glucose is above 100. So if the measured serum glucose is 600, it is 500 above normal. So it would be 5 times 1.6. If it's 700, then it's 600 above 100, so that would be 6 times 1.6. Everybody see that? Everybody see how do you understand now which number you plug in? Yes? Are you good with this or not? Okay. Okay. This is the glucose. This is a normal glucose. Let's say the patient's measured glucose is 600. You subtract 100 from 600. That gives you 500. Okay. The formula is you multiply 1.6. It's 1.6 for every 100 above normal. So you count in increments of 100. So if it's 500 above normal, then it's 1.6 times 5. And that gives you the number of milliequivalents per liter that the serum sodium is going to go down. So you would say, if the normal serum sodium is 140, you would subtract the number you get here from the normal serum sodium, and that's your expected serum sodium. Everybody see that? Is that good? There was another question, so they had their hand up. Okay. Yeah, you can round it off. Or you can do that if you want. It would be 4.3. Yeah. But it's just an approximation anyway.
And proper correction of the glucose with insulin fluid would, you would hope, bring the glucose down and the sodium back up to where it belongs.
Right. Right. Yeah.
One example you use saying that the expected sodium would be 132 for that example.
Yeah.
How far above or below that?
Oh, yeah, I don't know. They there's probably stuff in the literature like, plus or minus something, but I don't know what that is. It's basically a ballpark thing. I guess I'll have to look it up. But, for test purposes, it will be out. Okay? All right. So, the last thing we were talking about was the hyperlipidemia. Let's talk about the hyperlipidemia. Why patients with hyperlipidemia have pseudo-hyponatremia. So, patients with hyperlipidemia, say this is a test tube, okay? Now, let's say they have then let's say that the normal amount of lipids this much, okay? And let's say that somebody that has hyperlipidemia, maybe they have this. So if you measure serum sodium concentration. Okay? What I hope is obvious is that the serum sodium, which is represented by the red dot, the concentration is the same in both of those tubes. Okay? They have the same serum sodium concentration. Okay? But if you measure it, what the machine is going to do is it's going to measure the serum sodium in the total volume. Okay? But the sodium doesn't fill the lipid portion of the plasma, right? It only fills the water portion of the plasma. And so if you extrapolate the number of sodium ions into this whole volume, it's going to give you a low number. It's going to say, hey, you don't have enough sodium ions in this test tube to fill this whole volume and you have a normal serum sodium. Does everybody see that? They're counting this entire volume. Okay? Serum is not distributed, the sodium is not distributed into the fatty layer. And so you're going to get pseudo hyponatremia. So the serum sodium concentration in the plasma fraction, the water fraction, is normal. But in the total volume, it's going to be low because the sodium doesn't have access to the fatty portion of that volume. Okay?
Is there a lab test to distinguish those two?
Well,
Can they spin it down and separate it or something?
Yeah, I don't know. I guess you can. I mean, I assume that you get a supernate here, take it off, and just. But I think the important thing to be aware is that if you're dealing with somebody that has hyperlipidemia or hyperproteinemia, this is a possibility. And then it hasn't come up a whole lot, but I guess you could ask. There's probably a correction that you can do. There may be a correction. I don't have it in my notes that you can do based on like how do you compensate for the level of lipids or the level of the protein, or I guess you can go with the lab. Okay. And sometimes I think the lab will actually make a note if there's something like this going on with the sample that they receive. So I'll have to look that up. That's a good question. Okay. Again, one of the important things to remember, it's in figure 312 on page 59, is that the patient with SIADH is eubulemic. And again, bulimia is determined clinically, so they don't have any findings on physical exam of hypervolemia, such as edema. They don't have any findings of hypovolemia, such as dry mucous membrane, loss of axillary sweat, edging of skin, weight loss, or orthostasis on physical exam. Tachycardia. Again, it's clinical. That's how the determination of bulimia is made. Okay, there's a summary of everything that we've talked about for the last 40 minutes or so in figure 315, so make sure that everybody's comfortable with that and pathophysiology that underlies each of those conditions. And let's turn briefly to disorders of potassium concentration. And again, the next time we're going to focus mostly on acid-base stuff. Okay? So there are two possible disorders of serum potassium. Obviously, you can have hyperkalemia, which means that the serum potassium is elevated above normal. Let's say normal is 4.5 or something like that. 4.5 or 6, 4.5. An elevation above the reference range for that laboratory is hyperkalemia, and hypokalemia is going to refer to serum potassium concentration Disorders of potassium need to be taken seriously because they can cause ventricular ectopy, they can cause arrhythmias. Arrhythmias can be lethal. Somebody presents with obviously any kind of arrhythmia or CVC or any kind of ectopy, you need to make sure, am I dealing with ischemia? Make sure you're not dealing with ischemia, make sure you're not dealing with acidosis, make sure you're not dealing with hypokalemia or hypokalemia, because those things are correctable. And as again, the patient goes too old, it may be on you. So let's talk first about hyperkalemia. And the book points out that you can develop hyperkalemia from 3 different mechanisms. First of all, you can either increase somebody's intake of potassium, or you can decrease their urinary excretion, or you can get shifting of potassium across cell membranes. Okay? So let's talk about each of those in turn. First one, increased intake. They point out that it's difficult to induce hyperkalemia by ingesting too much potassium unless there's a problem with the kidneys, because the kidneys are pretty good at maintaining a normal potassium. But they do point out that we can do it if we try real hard. And they say it could be iatrogenic if you, for example, are using potassium at an inappropriately high dose intravenously. The other way we can cause hyperkalemia in people is by using potassium with a potassium-sparing diuretic. You don't want to do that. Potassium-sparing diuretic. You want to avoid using potassium with the potassium-sparing diuretic. Also, ACE inhibitors can also cause potassium to go up. And the point about difficult to induce hyperkalemia only works to a certain point. I remember there was a patient that I was told about one time when I was a medical student. They were having trouble keeping the potassium up. I don't remember exactly why. I guess she was on a diuretic or something. They tried giving her oral potassium, it didn't work. But finally, the physician said, "Well, go to the supermarket, buy the frozen orange juice. The frozen orange juice comes with a can." He goes, "Just eat it like sugar." So they made her potassium toxic by doing that. I guess she really liked the way it tasted. So you just need to be careful. Even though the kidneys are mostly pretty good at getting rid of potassium, you can still make somebody hyperkalemic by increasing their intake too much. The second way is by decreased excretion, and we talked about renal failure. Patients with renal failure, they have problems with, among other things, hyperkalemia. That's one of the things that you do to maintain potassium homeostasis. And so, one of the things that you see in end-stage renal disease is the development of hyperkalemia, or propensity towards the development of hyperkalemia. Other conditions besides renal failure that are associated with hyperkalemia due to decreased excretion, they're listed in your book. Besides the renal failure, they mention a decrease in the distal flow rate, in the distal nephron. I'm going to talk about that in a second. And hypoaldosteronism. So, patients who are underproducing aldosterone, unable to produce adequate amounts of aldosterone, are going to be prone to the development of hyperkalemia because of decreased excretion. Remember what's happening in the distal nephron. You have sodium potassium pumps, okay, to reach the urine, and it's a tubule, And what's happening is under the influence of aldosterone, sodium's going this way, and potassium's going this way with acid, the proton, okay? So if somebody has less aldosterone, then they're not doing this. Well, if potassium's not going out, and it's going up in the blood. Okay? Everybody see that? So that's the mechanism of hypoaldosteronism. And you can see hypoaldosteronism. Remember, renin, angiotensin, aldosterone. So you can see hypoaldosteronism, for example, in people who are on who are on ACE inhibitors. Right? Renin, angiotensin, aldosterone. You can't make angiotensin. Okay? You block the conversion of angiotensin into angiotensin. You can't make angiotensin, then you can't make aldosterone. Okay? You don't get release of aldosterone. So patients that are on ACE inhibitors are prone to the development of hypoaldosteronism and subsequently hyperkalemia. Okay? You can also see it. There's something called hyporenin hypoaldo. Hyporeninemic hypoaldosteronism, which is also referred to as type 4 renal tubular acidosis. Type 4 renal tubular acidosis. And you see this in patients, for example, that have diabetes mellitus. They're prone to the development of hyporeninemic hypoaldosteronism. So they're making less renin because of the effect of the diabetes on the kidneys. Since they make less renin, they make less aldosterone. Okay? Since they make less aldosterone, the serum potassium goes down. What do you think happens to their serum protein? It goes down. It goes down. The serum protein goes down, serum potassium goes up. Okay? Now they mentioned the decrease in flow rate, and I always have to look this up, and I always forget exactly how that works. So let me explain to you how that works. This is from a renal physiology. Okay? When the flow rate through the late distal tubule and collecting duct, I'm going to read you the reverse of what it says, because they're talking about an increase in flow. When the flow rate through the late distal tubule and the collecting duct decreases, the luminal potassium concentration is increased, which increases the driving force for potassium, which decreases the driving force for potassium secretion. Let's say this again. When the flow rate through the late distal tubule and collecting duct decreases, the luminal potassium concentration is increased, which decreases the driving force for potassium secretion. So one of the things that's going to here's blood, and here's urine. Okay? Here's the flow. Okay? So what happens is that as the flow decreases, what's going to happen is that water is going to tend to be, if it's going fast here, okay, then there's not a lot of chance for things to go back and forth across membranes, okay? But if it's going slow, then it gives time for the water to be reabsorbed, right? Remember we said you're going to get fluid ships across those membranes. So as it slows down, water has a chance to shift. What happens is that it leaves behind solutes, including potassium. Okay? And so the potassium goes from little potassium to big potassium, right? The concentration gets bigger. And one of the things that determines how much potassium finds its way from the blood to there is the difference in the potassium concentration from here and here. Well, as this gets bigger, the impetus to go this way is going to tend to decrease. All right? So that's why a decreased flow rate, a decrease in the urine flow rate, tends to produce hyperkalemia due to decreased potassium excretion. All right. The third way that you can get hyperkalemia, and this is an important way, is through intracellular to extracellular shift. And if you think about it, it's very important because the intracellular compartment is huge. It's very big, right? And remember that potassium is what's inside the cell, right? Sodium is mostly on the outside, potassium is mostly on the inside. So there's a tremendous store of intracellular potassium. Okay? So what is going to tend to make potassium, if you get movement of the potassium from the intracellular space to the extracellular space, you're going to get hyperkalemia. So what tends to produce that? Let me give you a couple of examples there. You get anything that produces weight out of cells, it's going to get the release of the potassium into the extracellular space. They talk about the role of pseudo hyperkalemia, like for example, if blood is drawn and the blood is left to sit around, the red cells lyse, they release their potassium, and then the lab reads the high serum potassium concentration, but it's not real. It's all a factor. But things that can produce true hyperkalemia would be, for example, the effect of acid-base changes on shift potassium across the cell membrane. So if somebody develops acidosis, the body wants to maintain its cell. The body wants to maintain a normal pH. If the pH is too acidic, it's perfect. Okay, so there's the cell. So you have lots of protons, right? The person dealing with an acidosis. So one of the ways it can buffer the proton is to send it inside the cell. Okay? So what happens is it sends the proton inside the cell, but it has to achieve electrical neutrality. So what comes out is potassium. All right? So as somebody becomes more acidotic, what you're going to see as the proton is buffered inside the cell is that potassium shifts to the extracellular compartment. So they develop hyperkalemia. So what you expect to see, for example, is somebody that has diabetic ketoacidosis, okay, when they come in, usually they're acidotic. Usually they're hyperkalemic, okay? Now, their total body potassium depleted, okay, because what's happening is that the potassium is coming out of the cells in large amounts, and then it's being lost in the urine as the blood is filtered through the kidneys, okay? So they have a tremendous potassium deficit that has to be replaced, okay? But the admonition is you don't start replacing the potassium until they pee, because they might be in renal failure, right? So after all, they have diabetes. It could be in renal failure. They don't want to get potassium if they're in renal failure. So you have to make sure that they it, and then you're going to start replacing the potassium with their total body potassium depleted. But they are going to have to do it. That's going to correct really quickly if you correct the acidosis. Or as you correct the acidosis. Other things that can cause potassium to move out of the cell. They list insulin deficiency or resistance that you can see in certain conditions. And this is a reflection or flip side of the coin, if you will, of the fact that insulin is used to treat hyperkalemia. Actually, I'm going to stop here because we're about 5 minutes over. So we'll take it up here next time.